Hello, everyone. Welcome to the session bringing stakeholders together to address violence in healthcare work community. I'm Kim Slade, and I am your moderator for this session. If you are in the wrong session, please navigate to the left menu on your screen to access the other sessions. This is a pre-recorded session. If you have questions for Henri, our speaker, please feel free to send them to hopeconference@abusehertz.ca with Henri's name in the message, and we will coordinate the response with Henri. So Henri Vanhulle is the Vice President of Client Outreach, Stakeholder, and Community Relations with Public Services Health and Safety Association. Henrietta has over 25 years of experience in the healthcare sector and occupational health and safety. She has a bachelor's in nursing degree and a master's of health service management. She is a Canadian registered safety professional and is also a certified occupational health nurse. She has spoken at provincial, national, and international conferences on the subject of workplace violence prevention, bullying, disability management, and healthy work environments. Henri received the Distinguished Alumni Award for Health Sciences from Fanshawe College in 2014 and was honored to be awarded the Lifetime Achievement Award from the Ontario Occupational Health Nurses Association in 2020. Among her many achievements, Henri is the co-founder of the National Alliance for Safety and Health in Healthcare, in which a majority of the provinces in Canada are actively involved. Henri was also integral into the development of the ministry-endorsed Violence, Aggression, and Responsive Behaviors VARB toolkits for the workplace violence prevention in healthcare, and is a key member of the Joint Ministry Violence Table. Welcome, Henri. We're so happy to have you here today.
Thank you, Kim, for inviting me. I'll just a couple things about PSHSA, or Public Services Health and Safety Association. We're one of the funded health and safety associations in Ontario through the Ministry of Labour, Immigration, Training and Skills Development. And our mandate is to assist workplaces in preventing workplace injuries and illnesses. And we focus primarily on the healthcare, education, government, and the public safety sector. So we work with organizations in these sectors to make sure they have the tools and resources to keep their workplaces safe and to make sure workers go home safely at the end of their workday. And, I'm absolutely thrilled to talk to you a little bit about collaboration in a work community and how engaging with our stakeholders has helped us to call attention to the issue of workplace violence in healthcare. And this was, as Kim mentioned, our VARB project, which stands for Violence, Aggression, and Responsive Behaviors. And just as a kind of a high-level overview, we began by collaborating with a group of stakeholders, and it led to some pretty amazing firsts, if I may say so myself, in Ontario. We ended up with a group of consensus-based toolkits that are not only being used in Ontario, but other provinces and across the US. There was a joint leadership table on workplace violence in healthcare that led to recommendations for PSHSA to develop even more toolkits. And it also led to the first ever occupational health and safety indicator required by Health Quality Ontario for reporting in healthcare organizations. So how did this start? Workplace violence events were increasing in number and in severity. And we heard that healthcare workers were worried about what might happen to them at work, as well as their concern about the psychological toll that frequent events would bring to them. After all, we had to think about how can anyone expect that a healthcare worker can provide exceptional care when they're working in fear or with burnout. So with support from the Ministry of Labour and the Ontario Nurses Association, we developed a plan to identify what prevention resources were needed to reduce this trend. So The toolkits that we developed were informed by our stakeholders, and that started with the initiation of a steering committee of largely employer and labor reps. And we used a logic model to ensure that we had clarity around the goals of the project. And we did this largely by identifying what our inputs would be, what our outputs would be, and the outcomes that we thought were important throughout the project. And it included things like how many stakeholders would we engage with, how many toolkits would we develop, what would be our short, medium, and long-term outcomes that we wanted to achieve. And as we were working on this project and this very complex logic model, we also identified that we needed to call attention to the issue. So we started with a small marketing strategy, and the goal of this was to increase awareness, educate people about the risk and what they could do to prevent workplace violence, and also to identify what images drove the highest engagement. And as you can see on the screen here, there were 3 themes to the marketing campaign. There was website targeting, there was location-based targeting, where ads kind of pop up on your mobile device when you enter a healthcare facility. And we also had targeted ads on LinkedIn. And with the support of our small working group, our initial steering committee, we came up with these 5 images by asking them what would resonate with our target audience, which were healthcare workers and people who would go to a healthcare setting for care or to visit a family member or loved ones. And as you can imagine, not everyone agreed on the images, but as you can see, we did get a good variety that we used. And when people engaged with these ads by clicking on the act now or do something about it or learn more, it diverted them to our workplace violence landing page so they could learn more about workplace violence. So this is what the landing page looked like. And these are some of the results. So as you can see, if you just look at the numbers, it was hugely successful. We had more than 2 million impressions. The click-through rates were higher than our average for this type of campaign across all 3 strategies that we employed. And we saw a lot of engagement across the healthcare sector. And as you can see here, the top 5 facilities for the location-based strategy were home healthcare, followed by chiropractic clinics, physicians' offices, mental health facilities, pharmacies, and then hospitals and medical centers. And the websites on the far right there that drove the most interest in services offered by PSHSA with the greatest interaction were actually news sites. And just in case you're interested, mornings seemed to have the best response rate, and Friday mornings were actually the most active. And the other important piece about engaging not just with our stakeholders to identify what marketing campaign we should use, but also to engage with the broader community, is that it helped us to identify what images resonated the most. So which image was most clicked through. So the one you see on the bottom left of the screen, not surprising, it's one that's showing empathy, was the one that people engaged with the most. So that was really helpful for us as we launched different components of the project. As you can see on this slide, this is the list of stakeholders who participated with us throughout the project. So not only did the marketing campaign generate interest in the general public and healthcare workers, taken off on me there, it also expanded interest in membership on our steering committee. So we had engagement from a number of people who had a vested interest in making sure that workplace violence incidents were decreasing and that workers were protected from injury. We had labor associations. So we had the Ontario Nurses Association, OPSU, CUPE, Unifor, and SEIU. We had employer associations, the Ontario Hospital Association, Home Care Ontario, the Ontario Community Support Association, the Ontario Long-Term Care Association, Advantage Ontario, the Police Association, and the Ontario Association of Paramedic Chiefs. And we had professional associations like the Registered Nurses Association of Ontario, the Registered Practical Nurses Association of Ontario, the Personal Support Workers Association, and Addictions and Mental Health. And we also, of course, had our funding ministry and researchers like the Institute for Work and Health who participated. And we really engaged these stakeholders throughout the design and the development phases to ensure we would have consensus in the final product. So not only did this steering committee provide guidance, they actually also recommended frontline healthcare workers who could participate in the development of the actual toolkits themselves. And the steering committee were the group who actually chose the 5 toolkits based on their knowledge of current gaps across healthcare as it related to workplace violence prevention. And then they helped us to promote them. So you can see here the 5 toolkits that were chosen by the steering committee were communicating the risk of violence, how to do a workplace violence risk assessment, improving security, personal safety response systems, which is how you call for assistance when you need help, and an individual client risk assessment. So the level of engagement from this very robust group of stakeholders generated interest outside of PSHSA as well. And partway through the project, the Ministry of Labor at the time and the Ministry of Health and Long-Term Care acknowledged the risk of violence in healthcare by striking a leadership table to further discuss what other tools and resources and solutions were needed in the healthcare sector, which was great because we knew at PSHSA we couldn't do everything ourselves. So the joint ministry table led to the development of a number of working groups, and that culminated in a report which included a number of resources and 23 recommendations for a variety of system partners. And 2 of the recommendations that came about as a result of that table also helped to promote PSHSA's work. Not surprising, I guess, all of the stakeholders that were part of the development of the first 5 toolkits wanted to stay on board to help with the subsequent recommendations that came from the leadership table. So the first recommendation that really led to a lot of PSHSA's work was for PSHSA to develop another 4 toolkits. So they asked for 4 toolkits: Code White, Work Refusal, Workplace Violence during Care Transitions, and Incident Reporting and Investigation. And the first 3 are already released, with the 4th to come out this fall. And we used a similar approach with the same group of stakeholders and working groups to help us to develop them. And the next recommendation that came about from the leadership table was to include workplace violence in quality improvement plans that are designed by Health Quality Ontario. So quality improvement plans have to be submitted annually by healthcare organizations, and they include a commitment to improve quality of care. Boards need to be accountable to ensure that the quality improvement plans are developed and that the boards are updated regularly on their progress. And so this was really exciting to us because it was the first time ever that a quality indicator was required that related to occupational health and safety. So the recommendation in a nutshell was that hospitals, long-term care homes, the community care access centers at the time, and primary care would include a narrative about how they would make workplace violence prevention a strategic priority. And then the second component, even more exciting, was that there would be a mandatory indicator for hospitals to report the number of workplace violence events that were occurring at their organization. So this was a huge change in the occupational health and safety world, and one that we were very excited about. The next component kind of our project was to launch a new website to house all these great toolkits, as well as the leadership table resources. And throughout the course of the last 5 years, we continued to engage with a number of marketing campaigns that were aimed at healthcare organizations, healthcare workers, and the general public. And all of that drove people to this new website. So if we look at kind of some of the ongoing traffic has happened since the launch of the workplace violence website, you can see the success of the campaigns on the graph here. The three little light blue shadings show when we've had subsequent marketing campaigns, in addition to the first one that I mentioned, as well as a number of events along the way. So each time we launched a new toolkit, we saw little blips. When we had a campaign, we saw increases. And this, the most recent statistics, I think that I'm referencing here are like over 58,000 users to our website. So certainly the collaboration, has led to a lot of uptake. If we drill down just a little bit further, you can see that uptake in the traffic on our website during one of our campaigns, and also during the International Violence on Healthcare that was held in Toronto in 2018, show a spike in use of the toolkits and the traffic on the website. And you can also see how an event like workplace violence being included in quality improvement plans by Healthcare Ontario drove traffic to our website. So this was, important information for us, and really helped us to engage with our group. So the ongoing engagement of the stakeholders and the development of new tools was absolutely amazing, and we learned a lot from all that variety of stakeholders. But we also really wanted to know if the toolkits were being used as we, set them out. So I'll briefly go through a little bit on the next few slides about the results of the evaluation we did with a third party. So overall, we found that like 3/4 of hospitals were aware of the toolkits, and almost 3/4 who completed the survey were using at least one of the toolkits. So that was amazing. But even more amazing is that the internal collaboration that happened with the Joint Health and Safety Committee. So 98% said they were promoting internal collaboration by utilizing their Joint Health and Safety Committees. And if we look at the toolkits kind of one by one, the Workplace Violence Risk Assessment Toolkit, 90% were using it. I mean, that was just phenomenal. And 71% said that it actually helped them to improve their process for assessing and managing workplace violence. And for the Individual Client Risk Assessment Toolkit, 68% were using or had reviewed the toolkit, and 55% of them said that it helped them to improve their processes for assessing the level of risk posed by individual clients. When we look at the Risk Communication Toolkit, 72% had used or reviewed it, and 47% said that it made it easier for them to develop or update their flagging or risk communication process. And for the security toolkit, 51% were using or reviewed it, and 42% said that it actually increased their confidence that their security program was aligned with the latest requirements or standards. And when we look at the fifth toolkit, 55% reviewed it or used it, and 42% said it increased compliance with applicable legislation and helped them to improve their existing response system. So I know that's kind of a lot of information that I was throwing at you, and I just thought I'd kind of wrap it up with what I believe were the keys to success in this project. One was having clear goals and desired outcomes at the outset, and this really helped us to keep everyone on track and make sure we didn't get into scope creep and all those lovely things that happen when you're implementing a project. And collaboration was absolutely necessary. We found that the participation was something that we couldn't do without. So this vast group of stakeholders really provided everyone, including us at PSHSA, with the issues and challenges from a multiple lenses. So from the worker lens, from the organization lens, from the system lens. And we identified early on that if we actually wanted the toolkits to be used, we needed this robust engagement and development and review process. And this led to us achieving consensus with the content of this toolkit. After all, if the stakeholders didn't agree with the value and the content of the toolkit, we knew that we would never get the implementation that we wanted. We also wanted to make sure wherever possible that we use the best available evidence to inform the toolkits. And as we worked through the project, I think we already knew how complex workplace violence was in healthcare, but we really found out that we couldn't rely on just pure research. And this led us to engage with actually a number of healthcare organizations right here in Ontario, as well as other jurisdictions, so that we could identify what were leading practices and promising practices that were happening out there. And as always, monitoring and evaluation is key. So as I showed you in the last few slides, we're absolutely thrilled with the results of the toolkit. And the last piece is ongoing marketing and communication. And as you saw with the analytics from our website and the number of peaks that occurred throughout the 5 years, each of them was actually attributable to either a marketing campaign or something else that was calling attention to workplace violence within the system. It could have been a campaign from one of the labor groups. It could have been the release of a toolkit. It could have been a conference or the launch of the workplace violence quip. But each of them helped to drive engagement of the resources. So, without the stakeholders having a part here, we really couldn't do this. So, in the end, we can't really thank our stakeholders enough. We don't think of these as PSHSA toolkits. They're actually the healthcare system toolkits. And without the knowledge and the support of the stakeholders, we would never have completed them, and they would never have achieved success that they have so far. So I hope you found this information informative, and I look forward to answering any questions you might have. Thank you.
Thanks so much, Henri, for the informative session. I think that many of the people attending today will find your approach useful as we move forward in exploring how to prevent intimate and interpersonal violence. So thank you so much. For the conference attendees, the next session will start at 4:05, in the main room for closing remarks. Thank you.